Occupational therapy from the University of Texas Health Science Center in San Antonio in 1996. 2 years later, she graduated from the Hand Therapy Fellowship Program through Texas Women's University and the Hand and Upper Extremity Institute of Baylor College of Medicine. In 2001, Dr. Rodriguez became a certified hand specialist or therapist. Recently, she earned a doctorate in occupational therapy from Rocky Mountain University of Health Professionals. Dr. Rodriguez has over 19 years of experience in the treatment of upper extremity musculoskeletal conditions and has owned a private practice in the Rio Grande Valley since 2000. She currently owns and treats patients at the RGV Hands Therapy Center in Edinburgh. Please welcome Dr. Rodriguez.
Thank you. Thank you. I'm just making sure this mic is working. So I'm going to go ahead and get started because I know I'm a little bit late and I know you guys want to probably get moving with some of these afternoon sessions. But I'd like to thank you for inviting me to SPATS and allowing me to present this interprofessional education program. And I invite you to kind of sit back and listen to this lecture. And I'll be sharing some of this information with you, speaker notes and slides via email if you all are interested. And so I'd like to disclose that I have no conflicts of interest during this presentation. And let me start by identifying some of the course objectives which our participants will be learning today is to identify common sports-related risks in hand musculoskeletal conditions, to recognize and evaluate common risks in hand sports-related musculoskeletal conditions, and utilize evidence-based interventions within the scope of your practice. And then I hope to boost your confidence in understanding these common sports-related injuries and conditions and treatment interventions consistent with this evidence-based practice. And so I'd like to give you a little brief overview since many of you may be asking yourselves, well, what is hand therapy? And it's defined as the art and science of rehabilitation of the upper limb. And it includes the hand, the wrist, elbow, and the shoulder girdle. So occupational therapists utilize theoretical principles, and they combine their knowledge of anatomy and biomechanics and the use of functional activities to prevent dysfunction, to restore function, or reverse the pathology of the upper limb in order to improve the individual's ability to perform daily tasks or occupations. So in this case, this would be your athletes or your students that are performing, sports activities. And so just like many of the medical specialties, therapists also have specialty areas in which they work, and hand therapy happens to be one of them. The Hand Therapy Certification Commission has defined a CHT as an occupational or physical therapist who has a minimum of 5 years of clinical experience, including 4,000 hours in direct practice in hand therapy. And so a CHT has completed a comprehensive test of advanced clinical skills and theory in upper quadrant rehabilitation. So in 2014, the Hand Therapy Certification Commission determined that 85% of CHTs in the United States were OTs and 14% were PTs. And so the domains of hand therapy that we'll be discussing today include domains 1, 2, and 3. And as we look at this diagram, the fundamental knowledge of basic science of musculoskeletal conditions of the upper extremity are required for each of these domains. And so the first 3 domains include the process of assessment and treatment of clients that may be similar to some of your practices in your respective clinics, either in schools or in private practice, which include evaluation of the upper limb, determining a plan of care, and implementing therapeutic interventions. And so I'd like to discuss 2 critical components that will assist the clinician in making evaluation and treatment decisions. And the first is the knowledge of anatomy and biomechanics. And this is a photograph that was taken of a group of physician assistants that were reviewing hand and wrist anatomy in order to diagnose medical conditions. And the intricacy of the hand and anatomy and biomechanics requires constant review, and even for the trained professional. And the second, of course, is the use of evidence-based practice, which is defined by Saxon and his colleagues as the judicious use of the best available evidence in making decisions about the care of an individual client. And we must recognize that the clinician expertise and patient values are components of this decision-making process. So in other words, research evidence alone does not guide our treatment approach. However, it does support the therapist in making effective clinical decisions for their clients. And so it's an integration of these three components that best describes evidence-based practice. So I'd like to briefly talk about the third domain, which addresses the treatment interventions. And these are adjusted over the course of the treatment as the patient's goals or the client's goals change, their level of acuity changes, and when their progress requires a need to upgrade their treatment plan. And we'll be discussing them briefly today. But educational materials in the form of home exercise programs should always be issued to each client in order to help them carry over their intervention plan. So at this time, I think each of you was given a bubble gum, and I'd like for you to place it in your mouth and start to chew, and we're going to discuss this before the end of today's lecture. If you haven't gotten a piece of bubble gum, just raise your hand, because I think there's somewhere over here. So here are some relevant facts about musculoskeletal conditions that we'll be discussing today. According to the Global Burden of Disease study performed in 2014, musculoskeletal conditions are among the most common reasons for medical treatment, accounting for 18% of healthcare visits in the United States. Approximately 25% of all musculoskeletal sports-related injuries involve the hand and the wrist. And I think we can agree that the incidence of these injuries is growing because of the competitive nature or level of high school and collegiate athletes. Obviously, traumatic injuries are most associated with contact sports, with football accounting for the highest incidence of injury. Stress and overuse injuries are related to the repetitive nature of athletes during intense practice or repetitive competitions. So many of these injuries have significant impact on scholarship opportunities for athletes, even when the condition has initially, or especially when the condition has been disregarded or there's a delay in treatment. And so the knowledge of common sports-related injuries and therapeutic strategies can help the athlete in returning to play within a timely manner. So let's begin to look at some of the most common injuries, and for the sake of time, I've divided these injuries into two different categories. And again, I went ahead and placed the most common injuries in this PowerPoint presentation, and they have divided them into the wrist and hand injuries, and then subdivided them into the radial-sided and ulnar-sided wrist injuries and hand and finger injuries. So let's talk first about radial-sided wrist injuries, with the three most common conditions on the radial aspect of the wrist, which include distal radius fractures, scaphoid fractures, and decurvaneous tenosynovitis. Distal radius fractures are common and accounting for approximately 1 in 6 of all fractures treated in the emergency room. They have various names, such as Smith's fracture, Barton's fracture, with Colles fracture being the most common. And the Colles fracture occurs 2 to 5 centimeters proximal to that radiocarpal joint. 80% of these fractures require some sort of reduction, either by a closed method or open reduction internal fixation. And approximately 50% of these distal radius fractures also involve the distal ulnar fracture, which is usually treated conservatively. Now, this classification system of these fractures can be quite extensive, and luckily, we have to understand that the higher number of these classifications, then the more complicated the injury, thus extensive the recovery. So the complication associated with these wrist fractures includes joint stiffness, of the fingers, of the wrist, of the forearm, and the elbow, and even involving the proximal shoulder region. And we'll talk more about stiffness later in this hour. Any other complications include maybe a malunion or radial shortening, distal radial joint dysfunction, and nerve compression resulting from the initial trauma, casting, or post-injury edema. Some important considerations for management of distal radius fractures is to improve and maintain digital mobility while the fracture is undergoing healing. And so this can be difficult with a significant amount of soft tissue injury or inflammation present with this condition. Maintaining the proximal elbow and shoulder mobility and strength is important, especially for the throwing athlete. It is important to begin postoperative treatment addressing wrist extension and supination as soon as possible, as these motions are typically more challenging to restore than wrist flexion or pronation. And since wrist extension plays an important role in power gripping, then restoration of wrist extension is definitely creates a stronger composite grip and power strength. And lastly, weight bearing and carrying of heavy loads is challenging after a distal radius fracture. So this is best reserved when the fracture is completely healed and the injured athlete is in the strengthening phase of treatment between 8 and 12 weeks post-injury. So now let's move on to scaphoid fractures. And they're the most commonly injured carpal bone, accounting for 60% of carpal injuries. And they occur with a high incidence in football players and an increasing incidence in female athletes, in which the athlete falls onto an outstretched hand. And interestingly, the degree of wrist extension determines a carpal fracture versus a distal radius fracture. And the carpal fracture results with the wrist hyperextension of more than 90 degrees. So the presentation of this injury can range from severe wrist pain to mild swelling and diminished range of motion. And athletes might complain of tenderness around the anatomical snuff box and pain with axial loading of the thumb during pinching or gripping. This injury can commonly go undiagnosed, and due to the subtle fracture lines at the scaphoid and the irregular contour of that scaphoid bone, which only can be detected 2 to 3 weeks post-injury through X-ray. The healing time for these injuries are highly influenced by the location and type of fracture, but typically long arm versus short arm cast or orthosis, followed by a wrist cock-up splint are utilized, which may be used for a few weeks even after the immobilization process has terminated. And these injuries usually require 6 to 12 week healing period, with proximal pole fractures requiring surgical intervention or longer periods of immobilization. So once again, active range of motion is initiated to all non-involved joints, including the fingers and the tip of the thumb IP joint. Once the fracture is healed and bone union has been restored, active range of motion is initiated followed by passive range of motion and strengthening within the client's pain tolerance. So we'll review some of the treatment recommendations for the stiffness that results from these injuries in just a bit. The last of the radial-sided wrist injuries is Decker-Vein's tenosynovitis, and it's an overuse tenopathy, which is probably the most common among athletes. Repetitive thumb extension and abduction can lead to thickening of the APL and the EPB tendons as they pass under the first dorsal compartment. And so I describe this condition simply by telling the client that there's an 18-wheeler that is trying to move underneath an underpass and simply cannot pass through. And so the provocative maneuver for this condition is tucking the thumb underneath the palm or in the palm under the fingers while the wrist is ulnarly deviated, which results in a positive Finkelstein's test. The conservative treatment for this condition requires immobilization in a thumb spica splint as seen here, stretching, nonsteroidal anti-inflammatory medication, and if the symptoms persist, corticosteroid injections are recommended or surgical intervention in which the first dorsal compartment release is performed. And so this injury is common during football season of athletic trainers because they're constantly cutting tape. And so it's highly recommended that if you're suffering from symptoms of Decker veins during football season, that you put your thumb in a thumb spica splint at nighttime and then intermittently during the day to resolve these symptoms. So now let's discuss some of the ulnar-sided wrist injuries, including extensor carpi ulnaris injury, the triangular fibrocartilage complex tears, and hook of hamate fractures. Talking about extensor carpi ulnaris injury, this is an ulnar-sided wrist pathology for athletes who play racket sports, such as golf, baseball, hockey, and tennis. And this injury may present as a tendinosis or a subluxation or dislocation or even a rupture of the ECU tendon. The pathology for this condition involves repetitive microtrauma or just a sudden traumatic injury resulting from wrist flexion, supination, and ulnar deviation, as with a double-handed backstroke in tennis or a downward golf stroke. And so this condition may present itself with ECU pain during resisted wrist extension and ulnar deviation, or tenderness along the ECU groove. And subluxation or snapping or popping can be present during supination, ulnar deviation in most severe cases. In some cases, the peripheral TFC tears can also lead to extensor carpi ulnaris tendinitis. And the treatment for this condition is like many of the other tendinopathies, which includes immobilization in a brace that typically maintains the wrist in extension and slight ulnar deviation in order to decrease the amount of stress along the tendon. Progression of treatment includes eccentric exercises, much like those performed with tennis elbow. The next is the TFCC tears, and this is an interesting structure because it's the major stabilizer of the distal radial ulnar joint and acts as a meniscus of the wrist or load-bearing structure of the carpus on the distal ulna. And so it's composed of the ulnar carpal ligaments, the triangular fibrocartilage complex, a meniscal structure, and then an articulating disc. And these injuries can easily result with twisting motion of a loaded wrist, as with swinging a baseball bat or a golf club. And so pain can be present to the ulnar side of the wrist during gripping, or clicking and popping can be present during forearm rotation. And some of the additional symptoms may also include instability of the distal radial ulnar joint, and pain can worsen with ulnar deviation. So the treatment for these is central tears can be treated conservatively and may require some sort of debridement or surgical debridement. Conservative treatment may include anti-inflammatory medication and the therapeutic interventions to decrease inflammation and restore range of motion. So I found success with this brace called a wrist widget, which was designed by a fellow CHT, specifically to help with resolving ulnar-sided wrist pain. And I think I was discussing with someone earlier about this splint. I keep them stocked at my office, and anyone who comes in with ulnar-sided wrist pain and is ready to return to either work or play gets one to avoid constant irritation of that TFC. So it's you can Google wrist widget on the internet, and you can, and I think various sites are currently selling them. Now, direct blows or contact blows with a golf club or baseball bat, or even repetitive stress impact injuries can result in hamate fractures. And obviously, the hook of the hamate is the more common fracture site. And this fracture can easily be missed, but symptoms include pain to the base of the hypothenar eminence, localized swelling to this region, and pain with forceful gripping, and resisted AB adduction, so abduction and abduction of the fifth digit. So a positive pull test, which is a best indicator for this condition, is performed by resistive flexion of the ring and the small fingers with the wrist and ulnar deviation. And the treatments for this is the excision of that hook or hamate is currently the standard of care. However, these fractures can be treated conservatively with immobilization for a 6 to 8 week period. And return to play is typically within 6 weeks of this surgery procedure, with hypersensitivity of this scar and the ulnar nerve being most problematic. So desensitization with this injury is definitely warranted. So now moving on to the hand and finger conditions, with the first two being hand injuries and the latter 3 or 4 being finger injuries. The first is the ulnar collateral ligament injury of the thumb, which are quite common and seen in skiing injuries, which is something that we're not going to see here in the Rio Grande Valley. But they can also be seen with basketball and football-related injuries in which the athlete falls on an outstretched hand and the thumb is radially abducted. And so pain, swelling, ecchymosis is usually observed along the ulnar collateral ligament of the thumb, and instability or joint laxity is noted with the thumb in extension as compared to when the MP is flexed at 30 degrees, and that is typically the most common indicator for an ulnar collateral ligament injury. And conservative treatment for partial tears involves forearm base thumb spike orthosis or cast with the thumb in slight flexion and ulnar deviation in order to take off some of the stress of the ulnar collateral ligament. The interphalangeal joint is free for movement, and this remains in place for approximately 4 to 6 weeks, followed by exercising involving very, very little stress to the ulnar collateral ligament or the thumb in abduction for additional few weeks. A contraindication is tip pinching, which is recommended until 8 weeks post-injury or post-immobilization. The goal for surgery is basically a stable and pain-free joint. So surgical intervention is recommended through various means of reconstruction, through the use of the palmaris longus for these full-thickness tears. And rehabilitation post-operatively can range from 4 weeks to 3 months in order to regain range of motion and strength for return to play. Once again, tip pinch is avoided post-operatively for 8 to 10 weeks post-injury to avoid stress to that ulnar collateral ligament. Strong considerations must be taken to avoid aggressive treatment with this injury, as ligamentous structures require more time to heal because of lack of blood supply. Next, we'll talk about metacarpal fractures, and they occur from axial loads of the wrist in flexion and account for 40% of all hand fractures. And these fractures require surgical intervention, especially if there's a significant displacement, angulation, or shortening of the metacarpal. However, they can heal rather quickly because of their good blood supply. And so examination should assess the rotational deformity, since very mild rotational deformity at the metacarpal joint, metacarpal can result in significant overlap of the digits. And while there's multiple methods for surgical fixation, including plates and screws, they offer a more quicker return to play and a stronger cortical foundation. So the treatment for these conditions can be difficult due to a significant amount of soft tissue injury and an imbalance between the intrinsic and extrinsic digital muscles, with the extensor tendon adhesions being most problematic. And they're very difficult to obtain even in the athlete who is constantly performing daily exercises. So these two pictures depict metacarpal fractures, and the first is that of an index finger metacarpal fracture of the index and the long fingers, and the second is a fracture of the fifth metacarpal, otherwise known as a boxer's fracture, which was placed in a custom orthosis. Interestingly, a systematic review by Pullman et al. On conservative management of metacarpal fractures concluded that there was absolutely no consensus on how to best manage metacarpal boxer fractures in order to improve function. And so no treatment with modality was statistically significant to any other. And so with this said, clinicians are are encouraged to use an arsenal of tricks to rehab these injuries. Another systematic review of metacarpal fractures by freehand reported that there was no significant harm with early active motion of metacarpal fractures, concluding there even may be some benefit into early active motion in flexion and extension. So the potential complications with these metacarpal fractures is significant joint stiffness and extensor lag of the involved digits. And we'll address some of these treatment recommendations in just a bit. So interphalangeal fractures of the proximal or middle phalanx can occur in a variety of patterns of trauma, and the athlete demands and status of the season usually dictate the common treatment for these conditions. So fractures can range from simple articular fractures requiring K-wire fixation or screws, or pylon-type fractures which require distraction fixators. And nicely, the distraction fixators that are made these days allow for early active motion, so we can see these clients early on in the clinic. Distal phalanx crush injury tuft fractures are typically stable with the surrounding soft tissue and the nail plate, which serves as a fixation of sorts to keep the distal phalanx in its position. So careful attention must be made to fracture dislocations, which are often looked over as a jamming injury, in which maybe a volar plate or avulsion may require surgical intervention. And for many of these injuries, buddy taping is sufficient and appropriate so long as a gliding of the soft tissue structures occurs over those fracture sites. So preventing contracture deformities of phalangeal fractures can be challenging. It's important to work on isometric extension while the digits are immobilized in an orthosis in order to counteract the strong-acting digital flexures. And so typically we'll see a finger flexion contracture just because of the weakness of the digital extensors. For these types of contractures, serial casting or plaster casting material provides a great 3 points of pressure to assist in resolving these PIP or DIP flexion contractures. The use of neuromuscular reeducation with a blocking orthosis can also assist with digital extension and flexion, and I'll show both of these in a photograph in slides to follow. This next injury is a central slip injury, in which results in the inability of the client to extend the PIP or flex the DIP joint. And this injury can quickly develop into a boutonniere deformity. And these injuries are often seen with volleyball or basketball players. And the treatment for these injuries requires PIP joint to be placed in full extension, not with a buddy strap, with a static finger splint. So the PIP joint needs to be placed in full extension to allow the central slip to heal and close at an optimal anatomical position. So leaving the DIP joint free for motion assists with pulling the lateral bands dorsally toward normal position and decreases DIP joint stiffness. So left untreated, these injuries can surgically be very, very difficult because they require a constant stretch of the soft tissue structures. So surgical intervention for chronic boutonniere deformities typically results in not so optimal results, and athletes should be encouraged to seek treatment in the acute phase of this injury. And let me go back, and here's a picture of the serial casting splint that I used to decrease the PIP finger flexion contractures, and then we'll go ahead and place them in a static finger splint in which the PIP remains extended and they're capable of performing DIP flexion exercises. The second finger injury is a mallet deformity to the terminal extensor tendon, which can develop with or without an avulsion fracture. It accounts for approximately 50% of all hand fractures and commonly occurs in the long and the ring fingers. And so it results after a forceful flexion of an extended DIP joint and results in an inability to extend that finger. The standard protocol involves an uninterrupted immobilization of that DIP joint in full or minimal hyperextension for 6 weeks, and then additional weeks of nighttime splinting. And so if an athlete is hypermobile and the PIP joint is already hyperextended, then immobilization of the DIP in extension creates the lateral bands to migrate dorsally, thus worsening the PIP extension. And so I commonly see this in a clinical setting where the DIP joint does not extend because the PIP joint is hyperextended. In these cases, the PIP joint is also immobilized in slight flexion. So a systematic review by Holland and associates found that neither a stack orthosis or a luminofoam or a custom orthosis, as seen here, are more effective for treating this injury. However, the use and design should be one that the client is compliant with. And so hypersensitive distal tip fingers can be problematic after this injury or an immobilization process. So when I talk about these mallet finger deformities, what I want to integrate is that the DIP joint needs to go completely immobilized without interruption or any active DIP flexion. Otherwise, the tendon cannot completely heal. And the last of these fingers injuries is a jersey finger, or rupture of the flexor digitorum profundus tendon, which results after a forceful hyperextension of the DIP joint and presents with tenderness over the volar aspect of that DIP joint. And it results in the inability of the athlete to flex the distal interphalangeal joint. This is definitely an indication and referral for an orthopedic hand surgeon. However, immobilizing the wrist and fingers in flexion helps preserve the tendon around its insertion and prevents migration of the tendon into the palmar surface of the hand or even into the carpal tunnel space at the wrist. And so this picture is a flexor tendon surgery in which the flexor digitorum superficialis and profundus were both repaired in multiple digits. And there's certainly a protocol that is followed with flexor tendon injuries. But what I'd like you to take away from this is the positioning of the wrist and MP joints in flexion, which is a good post-injury position if you suspect a tendon injury. So as we review these wrist and hand injuries, there's a cascade of healing events that allows the body to heal. And the phases of this healing include the inflammatory phase, the reparative phase, and then the remodeling phase. And it's important to understand these phases of healing because I've come to realize that through my experiences, knowing the phase of healing of the injured athletes and which tissues are injured, it allows me to make effective treatment changes and allow them to progress rather quickly. So while an incision may be healed after a laceration or surgical incision, I know that maybe the soft tissues, either tendon or ligaments, may require a longer period of immobilization to allow complete healing. And so the first phase of the healing is the inflammatory phase, in which the wound prepares for healing. And so it begins immediately after a trauma, and it lasts for several days and is characterized by inflammation, edema, swelling, due to the disruption of blood vessels and the release of histamine, bradykinins, and serotonin. And what it causes is a dilation of the blood vessels and increased cellular permeability. And so the tissues become red, hot, swollen, and painful. And so there's a proliferation of fibroblasts and osteoblasts, and then an invasion of leukocytes. And at this stage of healing, the collagen matrix is very weak and disorganized. And so the goals of treatment include decreased pain, decreased edema, and to promote wound healing as the inflammatory phase progresses into the reparative phase. And so this is the second phase of healing, and it lasts between 4 and 21 days after the injury, in which collagen formation is only about 15% of normal tissue tensile strength. And so as the wound begins to contract and shorten, and the disorganized collagen fibers begin to become randomly deposited throughout the wound, they invade that wound matrix to form a scar bridge across that wound. And so adhesions begin to form in between the synovial lining and also those joint spaces. And so this causes joints to have maybe a firm end field. So excessive force during this reparative phase can provoke an inflammatory response, causing additional collagen formation. So in this phase, clients can easily take 2 steps forward and 1 step back. So the goals of this phase are to decrease edema and gently begin stressing these tissue in order to prevent adhesions, all the while avoiding further creation of inflammation. The third and last phase of healing is the remodeling phase, and this is where we can become more aggressive with our treatments because the collagen fibers are stronger and more organized. And so interestingly, if active range of motion is limited during this phase, new collagen will be deposited in a very shortened position. And so during this phase, physical changes in scar length can be most influenced by you and me. And so what we need to understand is that scar is inelastic and it requires constant application of stress to promote permanent elongation. And so this is why your athletes may continuously say during this phase that they feel stiff and it's reoccurring stiffness on a daily basis. So the goals of this phase are to introduce controlled stress as that scar tissue matures in order to influence scar formation, to begin movement or re-education through passive and active range of motion exercises, and to reintroduce function through strengthening neuromuscular re-education and functional activities. So now we've discussed a little bit about the phases of healing, we can establish the goals of treatment, which are to restore range of motion and strength, to influence scar formation, to prevent contracture and prevent permanent disability or deformity, and provide effective treatment interventions which will allow athletes to return to function or play. And so we do this by fulfilling our rehabilitative goals and evaluating many of the components of an injury in order to identify every problem, which may be contributing to their lack of inability to either move or play. So this evaluation process for our injured athletes may involve range of motion, strength, prehension, sensation, edema, soft tissues, muscle atrophy, pain, wounds, postural, and functional limitations. And so this evaluation process must be thorough and detailed to establish an effective treatment. And so in this case, you may be treating a central slip injury when in fact there is an ulnar nerve injury with similar presentations. And so as clinicians, we must treat the problems that we see and not necessarily the diagnosis that we read. And so remember that the phases of healings are not always similar from client to client because many other factors can influence healing, such as previous injury, underlying medical conditions, nutrition, the use of caffeine and nicotine, which significantly impairs the ability of ligaments and tendons to heal, or the nature or extent of an injury, such as an open, comminuted fracture versus a closed, non-displaced fracture. So the treatment should be based on sound understanding of wound healing and knowledge of anatomy and biomechanics of the condition. So this is how the relationship between the therapist and the athletic trainer can be beneficial for our clients, and it can assist our athletes in returning to play as soon as possible. So at any rate, a plan of care must be effective when you put your plan into action. So what is it that we're treating in therapy? And most often, our treatment will target resolution of post-injury stiffness. And so the definition of stiffness is the rigidity of an object or the extent to which it resists deformation in response to an applied force. And so on a cellular level, stiffness occurs when gliding motion is restricted in inelastic banding of collagen fibers. And so we all know this inflammatory process and scar formation extends into the adjacent digits because of the proximity of the inflammation, and it makes everything stiff and painful. And so let's discuss some treatment strategies and how to resolve some of this resolving cycle of stiffness, which can be very frustrating in a clinical setting. So let's begin by discussing some of the physical agent modalities. And I'll be honest, we don't use a whole lot in the private practice setting because of reimbursement issues. So I'm going to talk about the ones that we use probably a little bit more often. But superficial thermal agents are applied to the surface of the skin in order to change the tissue temperature. And this improves the healing process by decreasing inflammation and increasing the blood flow and promoting cellular activity for the tissues that are trying to heal. And a study performed long ago by Laban in 1962 determined that as collagen tissue temperature exceeds 45 degrees Celsius, there is a 25% increase in the potential for the elongation of scar. And so this is why we use physical agent modalities such as ultrasound, low-level laser, flutotherapy, or hot packs and hand therapy in order to increase cellular activity and heat the tissue. And so when I ask that you use these modalities in your facilities, in your training offices, that you think about the goals that you're wanting to achieve. So if your goal is to improve flexion, then place the wrist or the finger in a flexed position. And if your goal is digital extension, then make sure you're providing a stretch in that direction. So oftentimes I'll go into a clinical setting and the patient's hand is placed directly like this with a hot pack wrapped around it. And I'm like, well, I mean, you're kind of providing the same thing as them putting their hand outside in 100-degree weather. So if you're wanting to provide a stretch and you're wanting to gain flexibility, either an extension or flexion, place their hand in that position. And we use dowels, we use towels, and we wrap them up if we want a little bit of flexion, and they can only achieve, that much. So make sure, again, as we're using like the ultrasound or laser, that we use it either in extension or flexion, or even constant motion as we're doing it. The effects of edema actually are probably the worst of treating an individual and can pretty much be devastating. So controlling this edema is the key to regaining functional mobility in both the wrist and hand injuries. So these pictures depict how we use edema-controlling devices in reducing the edema through the use of an edema glove, utilizing Coban wrap or bandaging, and of course, elevation with active motion. So motion is lotion to prevent scar tissue adhesion, so constant movement encourages that increase in cellular activity. Preventing scar tissue adhesions through the use of a scar mold fabricated from elastomer putty, friction massage, myofascial release, high-intensity continuous ultrasound, soft tissue mobilization, and muscle and tendon gliding exercises loosens superficial scar adhesions and allows tendon gliding and flexibility. So utilizing instrument-assisted soft tissue mobilization techniques such as the Graston tools also creates controlled microtrauma, which can elongate soft tissue. And once again, as you're doing the modality of choice, then putting the wrist in extension as you're stretching the scar tissue is recommended. So now let's talk a little bit about tendon gliding exercises and functional activities. And they're utilized during the very first and second phases of tissue healing when there's little or no resistance applied to those healing structures. And so these exercises involve a combination of very rote exercises, but also simulated functional activities which can inhibit muscle co-contraction when performed bilaterally. I encourage everyone to use a bilateral approach when you're trying to gain flexibility initially early on, and it decreases pain and promotes normal movement patterns. So the inhibition of this co-contraction is important because if you're driving down the road and your foot is on the gas pedal and the brake pedal at the same time, you're just not going to get very far. And that's what happens when you initiate movement and there's a co-contraction. So performing these functional exercises also promotes cortical remapping and the integration of normal movement patterns, which has been ingrained into the brain of your athletes for many, many years. So utilizing normal movement patterns, I have the clients close their eyes and do normal activities that normally they would do on a day-to-day basis, and sometimes that just includes grasping of small cones or maybe a highlighter or something like that, allows the remapping or cortical response of the brain. And so the exercises should be performed to end range, hold for at least 5 seconds in order to facilitate that maximum voluntary effort. So sets and reps are performed as appropriate, 3 sets of 10 or 15 repetitions, or even timed 3 to 5 minutes. So these are some of my favorite devices, and what they do is they redirect the forces of tendon excursion in order to achieve a desired range of motion. So the cam orthosis that's seen here on the left places the MP joints in flexion and redirects the digital extensor forces to extend the PIP joint. And this can be done through a taping technique with foam, but it also can be done with just a small piece of thermoplastic material. So this is beneficial during proximal phalanx fractures where the extensor hood gliding is limited and adhesions may be present. Of course, buddy strapping is utilized for providing additional digital flexion gliding from the adjacent digits and to gain motion to the involved finger, or to prevent scissoring and crossover of the digits, which may be the result of a metacarpal fracture. So let's talk a little bit about passive range of motion. In my personal opinion, I always tell my clients that injured tissues do not respond, hand and wrist injuries do not respond well to the no pain, no gain theory, and that stressing the tissue too aggressively can lead to loss of range of motion as you cycle once again through that reparative phase of healing rather than moving through it. And so careful with aggressive passive stretching, and you must consider that you are stretching the tissue and not trying to tear it. So the force should be steady, providing a very low load prolonged stretch in which the client should be relaxed, and I don't think that baby looks very relaxed. So here are some methods of passive stretching which involve static progressive stretching with orthosis or the use of Coban. And so we do utilize joint mobilization techniques as seen up in the upper right-hand corner with, for instance, wrist flexion glide, in which you provide a very low load prolonged stretch of the involved tissue. And so towel stretching exercises is the one seen on the lower left corner, are utilized in order to regain the difficult form rotation, which is supination after a distal radius fracture, and is also very, very functionally important. So again, you could start with a gentle stretch and have the client adjust the tension as tolerated, and we do no less than a minute stretch. And there's numerous activities that we utilize in the clinic in an early setting and an early phase of recovery. So the treatment is tailored to the types of activities that are more challenging for the individual, but most importantly meets the client's needs. And so most often, we're constantly evaluating the clients in a clinical setting, asking whether the exercise provides a challenge, and if not, we rapidly progress through that. So as we enter the strengthening phase and mobility is regained, graded resistive exercises are added to the treatment plan. And I've included numerous pictures of some of these items that you may have in your training rooms or in clinical settings. The top picture can be used with various dowel sizes or highlighter or a pen. And the bottom pictures are strengthening utilizing Russian stimulation to assist with digital flexor tendon excursion. And so in order to provide this excursion, the red electrode or the dead one, the base, is placed on the dorsum of the wrist, and the active electrode is placed on the forearm flexor, and that creates digital flexor contraction. So the TheraBand can also be utilized in various fashions to improve digital and wrist flexor and extensor strength. And so many times I'll often do these TheraBand exercises, and the patient right away wants to do like bicep or tricep. I'm like, no, this is for finger and wrist extension and flexion exercises. So once again, these may be some of the items that you have in your office, or can be easily made by some of your training students. I like to incorporate various movements within a single exercise so that the exercise can involve various movement patterns. And so with this Velcro board exercise, it involves digital flexion combined with wrist extension and flexion, as well as digital extension and wrist stabilization. So the power whip can be utilized in various fashions as well as the clothespin for either pinching, tip pinching, tripod pinching, or lateral pinching, or even composite fisting. I encourage many of you all to think about incorporating proximal strengthening program into the healing phase of any type of injury when possible for the athlete who needs to maintain proximal stability, strength, and for return to play. I don't know any athlete who doesn't need proximal stability strengthening for return to play. So even if they're casted, if they're immobilized, I might encourage some TheraBand exercises. It also provides a therapeutic outlet for many of your injured athletes, which are so active and then sidelined during an injury. Cardiovascular activity is also highly encouraged to increase blood supply and promote healing process through the circulatory system. So I would caution you with having them do any types of activities that will create microtrauma, such as running outdoors or doing excessive high-intensity workouts. Endurance training can be sport-specific and can include weighted balls, plyometrics, weight-bearing activities, concentric and eccentric exercises, lifting, carrying, pulling and pushing, open and close chain exercises, isokinetic, PNF exercises, but care must be taken to evaluate the injured structures during the first few endurance treatments to avoid, once again, them cycling through that inflammatory phase. This is a piece of equipment that basically simulates functional activities and grades the resistance of their activity according to the patient's maximum ability to perform resistive activities. And while many of you may not have this equipment in your clinical setting, these activities can be simulated by opening resistive jars, using a screwdriver and nuts and bolts, gripping and pinching heavy lids and opening doors. And this program can also be tailored to be sport-specific, utilizing or shooting of a basketball, hitting a volleyball, utilizing a tennis racket, or throwing a soccer ball. And so this has to be my favorite activity and exercise, functional, simulated, and return to sport training. And this, it's almost kind of like one of those no caption needed slides, but slowly returning the client to doing the activities they love to do, and the athlete will stay compliant and engaged with the therapeutic program. So we only take a component of what they're capable of doing or what they have to do. This is a young lady who just started a rotator cuff strengthening program, and she does very soft, just rotational movement to be able to try to gain some of that softball activity. And this is a young gentleman on the right side that's a baseball player. He's only a few weeks post-metacarpal fracture injury, and just holding a baseball in his hand, just made the world a difference. And when I asked him to bring it in, because I don't have some of those items, when I asked him to bring his glove, he just smiled as if we were going to go play baseball somewhere. But that's not the case. Just getting them back into their normal routines can make the biggest difference. So neuromuscular re-education or Russian stimulation is also one of my favorite exercises, and it gradually improves the athlete's strength and endurance. And for improving, again, composite flexion, that's something that I use all the time. During the strengthening phase, I also use a MAC blocker or isolated tendon gliding exercises in order to stimulate the flexor digitorum superficialis or profundus tendons. And you can use a blocking dowel. You can use your other hand and just simply block the tendons while you're doing the stimulation. So this is just some other ways to utilize some of the equipment that is in our clinic. So the next two slides are basically where I demonstrate the objectives for both immobilization and mobilization orthoses. And immobilization orthoses can assist with providing symptom relief, positioning of the edematous structures, maximizing voluntary use, maintaining tissue length, protecting healing structures, and improving joint alignment, protecting fractures, or maybe reducing contracture of spastic muscles. So here are just a few pictures that help describe the immobilization orthoses, or splints fabricated out of thermoplastic materials. Some of those are, I guess the middle one is also just something that's prefabricated and a resting hand splint that's utilized at night. So Jacobs and Austin in 2014 discussed the rationale for fabrication of mobilization orthoses, and studies have determined that controlled tension applied over time alters cell proliferation. And so this is the premise for dynamic or static progressive splinting that stimulates the living cells within the contracted tissues. And this occurs through the constant external tension. And so common objectives for mobilization orthoses include the remodeling or maturation of scar tissue, the elongation of soft tissues, increasing passive range of motion, realigning of joints and ligaments, and for substitution of weak muscles. And so critical thinking is necessary in order to determine the best approach for designing these orthoses, either simple or complex, for simple or complex injuries. And so here are a few pictures that help describe that mobilization orthosis. Mobilization orthosis can utilize dynamic rubber band traction or static progressive approach to help provide that constant stretch. And so in conclusion, many of the conditions that I've discussed today can be rehabilitated in a manner that allows the injured athlete to return to play, assuming that the treatment is appropriate and effective. So this can only occur with great understanding, again, of the wound healing and knowledge of anatomy and biomechanics. And I think protocols can be used as a guide for treatment, but not as a rigid plan of care. And so there's a collaborative effort between the therapist and the athletic trainer that is required for returning these athletes to competition and to achieve functional outcomes. And so it's our interprofessional education and relationship that allows us to guide these treatment plans and allows us clients to become more functionally mobile in the field and in their respective sport. And so many of you might be wondering why I had to begin to chew the bubble gum. And so, well, let me begin by saying that many of our clients and our athletes have different learning styles. And so I gave you a piece of bubble gum today to give you an idea how I describe the scar formation process to my clients and to their family members, or to anyone that comes through my clinic. It doesn't matter what age. And I start by saying the scar formation is like a piece of bubble gum. And as you begin to chew the gum, you have lots of sugar in that gum, and you're able to mold it, and you're able to chew it, move it from side to side. You're able to expand it and maybe make a bubble gum. But it's very much like the disorganized collagen fibers that are similar to those as the healing wound begins to heal. And so as you continuously chew that gum, the sugary substance, you kind of swallowed that, and it kind of became a little harder and firmer. And that's like the second phase of the healing process. And then at some point, you became tired of that gum, and some of you even took it out of your mouth, or some of you maybe even trying to chew it, but in a very difficult fashion. And that is the latter part of the healing process. And when I tell clients that this is the way their body heals, and that there's a window of opportunity to regain motion and function, they kind of seem to get it a little bit more than them looking at me and me telling them what's going to happen in the course of certain weeks. And so when you want your athletes to follow your instruction, give them a visual photograph, send them an email via text message, videotape them doing some of your exercises, and make them part of their own recovery. Let them understand what the injury is and how it affects their ability to return to play. And so I always tell my clients, you're your best therapist. I'm just kind of like your teacher. And so be the very best instructor that you can, and through the utilization of some visuals, such as the one I've given you today. So this is our logo at RGV Hand Therapy, and it was designed for all those that walk through our office in hopes of returning to those activities they love to do. I know that you all wouldn't be here expanding your knowledge if you didn't love what you do, and for that, I thank you for your time this afternoon. Thank you again, and I encourage you to email me if you have any questions. Feel free to email me if you want a copy of the lecture with all my notes. I'd be happy to share that with you. doing a drawing?
Heads up, heads up. Heads up.
Sorry, hey, you guys got to wake up, man. Okay. Sorry about that. I'll give you a Coke. I got you a Coke over there in the registration desk, free of charge. Okay, we're going to give away a insulated beach bag. Ruth Grasty. Ruth Grasty. She here? Nope. Jesus Garcia, Flower Bluff. There he is in the back. We're going to give away, yeah, you want to give away that one too? Let's give away something else. A Sea Life Cruise for 2. Or would you rather me give away the bag? Sea Life Cruise for 2. With the bag. Jaime Perez, San Marcos, right over there. $15 Whataburger. $15 Whataburger. Carlos Presas. Carlos. We've got a pint from Padre Island Brewing Company and a $10 gift certificate inside. Padre Island Brewing Company. Larry Lejo. Where's he at? Larry, come on, man.
Oh, I got it in my neck. It's something in my neck.
Ben Garcia from Lyford. Nope. Oh, there he is. Okay. We've got 20.